For those of you who aren't familiar with Women's Health Victoria, we're a statewide not-for-profit organisation. We're supported by the Victorian government, the health sector, and we work with the Victorian government, the health sector, and the community to improve health outcomes for women, including cis and trans women and gender diverse people. Accessing optimal healthcare is a fundamental human right for us all. Yet women and gender diverse people still face deeply rooted challenges in accessing equitable care from a health system that was never built for or with them. As a leading feminist organisation since 1993, we advocate on behalf of people facing bias and discrimination due to their gender and other social determinants of health. We empower women and gender diverse people to navigate healthcare systems and to make informed choices about their health. And one of our most exciting recent initiatives is a new online resource for women and trans and gender diverse people over 50 called In My Prime. It was launched in September last year, and it addresses the lack of positive representation of one of the fastest growing groups in our society and the lack of tailored health and wellbeing information for this group. Briefly, it features an incredible gallery of empowering nude images of older women with accessible, tailored information of relevance to this group. It covers everything from menopause to brain health, to navigating changing relationships as we age and maintaining our independence and autonomy. All the information on the site is evidence-based, which is important given how much misinformation is out there in the online world today. It was also developed in consultation with women and trans and gender diverse people over 50 from as wide a range of experiences and backgrounds as we could manage in the time we had available. We held focus groups with people with lived experience before starting the website design. We did keyword research to find out what health and wellbeing information women over 50 actually search for online. And then as we embarked on developing the website content, we held 3 workshops with an advisory group, which was made up of lived and living experience participants, clinicians, advocates, and people working in older women's health and rights more generally. But notwithstanding this, we know that the website has some limitations in this regard and that it could be more inclusive, which is why we're holding this webinar today, as this challenge we recognise is not unique to In My Prime. It's one that all digital health content creators face. So we've brought together this panel of people who have highly relevant perspectives and experiences on this topic to share and discuss. So I'm going to now introduce our wonderful facilitator, Ruth De Souza. We asked Ruth to facilitate this panel. It's quite funny, Ruth, having your face up there and seeing you as well on my screen is probably a little unnecessary. We asked Ruth to facilitate this panel because we have so much respect for her experience, knowledge and keen insight, as well as her ability to facilitate conversations with respect, humanity and humour. Ruth's background in nursing and health education means she understands the complexities of healthcare delivery and health promotion and the need for more inclusive and accessible services. Thank you, Ruth, for joining us today. I'm going to hand over to you now and stop sharing my screens, and I'll let you introduce our wonderful panel of speakers.
Hello, everybody. Can you hear me?
We can.
Awesome, awesome. I'm having this weird morning where I put the silver eyeshadow on and purple lipstick to look good. And I'm just having a few sound problems, so I just wanted to check. So exciting to be here. And I want to acknowledge the countries that you're all joining us from today. I'm an uninvited guest on the unceded lands of the Bunurong language group on the Bass Coast of Victoria. I'd also like to acknowledge all the First Nations people joining us and their elders past and present. Always was and always will be Aboriginal land. I also want to acknowledge that we're here having an important conversation. And I wondered if I could ask us to just take a deep breath together collectively because I'm conscious that so many people don't get the privilege of aging. So just to ground us, to arrive, can I invite you all to do that? Thank you, everybody. Jamie Lee Curtis, in a speech at the Radically Reframing Aging Summit in 2022, said, "The word anti-aging has to be struck. I am pro-aging. I want to age with intelligence and grace, dignity, verve, and energy." And what we know is that the disempowerment and humiliation of older women in the broadest sense is one of the most long-standing and unchallenged effects of patriarchy. As a result, aging women are often engaged in an indecorous struggle to deny their experience and to act as if we are still young. So I believe this conversation we're about to have and the amazing resource that Women's Health Victoria have developed is going to help us with this. As Sianan said, the website brings together accessible and evidence-based health and wellbeing information on a range of topics. It also has nude pictures. You got to look at the nude pictures. They're really amazing. They're a celebration of women. So it's my great pleasure to introduce our panelists today. We have the amazing Michelle McNamara, the Treasurer of Transgender Victoria and in my Prime Advisory Group member. We've got Vicki Kearney, Women with Disabilities Victoria Experts by Experience Research Project participant. Catalina Labra Odde, who's the Research Advocacy and Policy Officer at Multicultural Centre for Women's Health. And last but not least, Jackie Boyle, Head of the Health Systems and Equity Directorate at Eastern Health Clinical School, Monash University. So I'm going to get straight into it. And if you've got questions or comments, please put them in the chat. We've got a really tight timeline, so I don't think we're going to get to them, but I think Sianan and others will capture them in some way, and it might inform a future conversation. Is that a good plan, Sianan?
I think that's an excellent plan, Ruth, and we can also share them if we can find a way to do so with people as well.
Beautiful. So I'm going to get started with the first question and maybe ask everybody on the panel to talk about what they see as the most pressing health and wellbeing issue for older women, both cis and trans inclusive and gender diverse people. And maybe I'll get Michelle to start for us.
Right, thank you. Yes, I suppose the pressing issues that I see for older women is really accessing appropriate health care. I think the challenges are very, very great for older people. As we age, we need more help and more supports for our health, because our health will inevitably be challenged by the aging process. And so accessing the appropriate supports is quite a challenge. I think everything that I say about cis women will be amplified for trans women, because they experience a history of real discrimination in accessing healthcare. Not that cis women don't, but trans women experience a history of discrimination in accessing healthcare. And that history, we know from studies, prevents them from actually seeking out help often until it's far too late. So there's so many trans people will only seek help for cancer when they're in the stage 4 terminal stages, instead of seeking help early. And everything we can do to encourage women to lead older women to lead a more healthy lifestyle would be will help everybody, I think. What inspires me about the In My Prime website is that it takes a very holistic view of health. It says it's not just what services you access from the healthcare system. It's what you do for yourself, and it's how you stop yourself being socially isolated. So I've gone on for long enough probably, but there's a very comprehensive resource on the In My Prime website, and Women's Health Victoria are to be commended for doing that.
Thanks, Michelle. Maybe I'll go to Catalina next.
Thanks, Ruth and Michelle. I want to follow on from that point on access to healthcare being a really pressing issue. And also, as you were saying, Michelle, access to that health information as well. So I think in talking about digital technologies interlaced with healthcare access and information, I think it has a huge potential to increase access, but it also has, if we're not applying an intersectional lens, it can also reproduce existing inequities, and in some cases make access more difficult. So I think how we use digital technologies to increase access to healthcare is also really important. And COVID-19, I think, kind of showed that when we started relying a lot more in digital technologies for health. And for example, telehealth in some cases increased access, but in some cases also made it more difficult. For example, if you didn't have access to Medicare, that was still a very costly service. So for many temporary migrants, there was another barrier as well to accessing something that was supposed to make access easier. So it's just keeping those things in mind of how we use digital technology to also increase access.
Catalina, that's fabulous. And someone's just decided to cut a tree in the neighborhood. This was the joy of digital technology, isn't it? That we got to have intimate, close-up views and of other people's lives. I think that's a really nice overview you've given us, Catalina, and we'll be talking more about digital health soon. But I wonder, Vicki, since Catalina talked about the pandemic, whether that's also something that would follow nicely for you to go next.
So I think that we as women have been groomed to be good patients rather than advocates for our own health. So there's a definite power imbalance in the relationship with our health providers, and we buy into this by accepting their diagnosis based on assumed experience and education. But the truth remains that many women's health concerns are under-researched, underdiagnosed and undertreated. So gaslighting and diagnostic overshadowing occur where gendered ageism result in symptoms being delegated to age and menopause. So patient-centred care and trauma-informed practice are the gold standard for our healthcare system and are slowly gaining traction, but both rely on time being allocated to allow for a relationship building. So a key part of patient-centred care is you becoming involved in your own healthcare. This means you choosing to be included in all decision-making, healthcare planning and goal setting. So your healthcare professional should give you the information and access to information that you need to make informed decisions. And this information needs to be in formats that you understand. You should also have the time and the opportunity to ask as many questions as you want to and talk to your carers, family and friends before making informed decisions.
Well, that tree and that mulch are really going for gold in the neighborhood. Vicki, you've highlighted so many good points, and I'm going to go back to you later on to talk a bit more about gendered ageism and gaslighting, because I think you've raised some really critical points that I'm keen to talk about. Jackie, what are your thoughts about the most pressing health and wellbeing issues for older women?
I think that some of the ones around healthcare have been really well outlined. There's a lot of work to be done. I think that having part of people being able to make informed decisions and have shared decision making with their healthcare providers does mean that they need to be well informed, and having digital health resources that are available and accessible to everyone is very important. I think also it's a bit beyond health, but I think all those broader determinants, the increasing homelessness that women experience entering retirement, for example, I think they're all issues that are really impacting on women's health as well, and social isolation and activeness are really important things that we also need to consider.
One of the things that I'm thinking as you're talking, and that has me slightly worried, is that a lot of the strategies that everyone's been talking about depend on individuals, like we're not talking about structural and systemic solutions. So I hope that maybe you can think about those as we move through the webinar, because I think there's a lot of kind of assuming, not assuming, and I'm not talking about this panel, but I think there's an expectation that we'll be informed consumers in general, and that we'll actively take part in managing our own health, which I think are all very neoliberal kind of edicts that mean that if you're someone who might struggle to access a health service, and it might take a lot of guts to do that, time, resources, energy, etc. And then you have Vicki's experience of being gaslit, I think you put it. And, like you said, Vicki, we're being groomed to be good patients. There are a lot of challenges, aren't they? And Vicki, I'm wondering if you could say a little bit about gendered ageism and its health impacts, and maybe why, particularly as Shannon pointed out, we need these kinds of intersectional conversations, and as Michelle has already pointed out to us.
So the gendered ageism is part of an intersecting factor, so that it can also include things like discrimination, stigma, poor health literacy, lack of accessible and culturally appropriate services, gender norms, socioeconomic disadvantage, geographic location, ethnicity, and disability. So that's a lot of things that can intersect. And these can act as barriers both to help-seeking behaviours and receiving timely and appropriate healthcare. So really, we're looking for our health system to incorporate trauma-informed care. So it's an approach to service delivery based on understanding the ways that trauma affects people's lives, their service needs, but also their service usage. So it incorporates principles of safety, so ensuring people are physically and emotionally safe, choice, giving individuals choice and control, collaboration, where we're sharing decision-making, and power. So again, going back to that power dynamic. Trust, which is a consistency, and making sure that your services are consistent is very important, and interpersonal boundaries, and empowerment, so prioritising enablement, which means that you're allowing the person to be a part of that group that's actually working to support their own health. So it acknowledges that healthcare organisations and care teams need to have a complete picture of a patient's life situation, so past and present, in order to provide effective healthcare systems.
Thanks, Vicki. Beautiful, beautiful answer, and so comprehensive. I wonder what your thoughts are about gendered ageism, Jackie, and also thinking about Vicki's very kind of holistic, very holistic idea of the health system.
Yeah, I mean, I think that it's all really important, and as well as having that, culturally responsive approach to healthcare as well. And unfortunately, I don't think our systems necessarily are set up well for that. So when you talk about it being more than just an individual issue, I think, that is where health systems and health services really need to think about addressing those things that Vicki has raised. And I think, that's where those other sort of more social issues come in as well, around gendered ageism, with the inequality and pay across the life course that leaves us with less superannuation, less income, and more likely to be homeless when we were older. Again, there are systems issues that need to be addressed.
Can you say a little bit more about this life course approach?
So, well, I think that for, if you do take that intersectional approach, I think that women who or for women or any individuals who identify as women or other genders will often experience discrimination across their life course. And if they have other factors that are affecting their life, if they're from a disadvantaged socioeconomic situation, those things compound across our life course. And, it's not something that just all of a sudden arrives when we're older. So ideally, we would be addressing those systems that address all of those things across the whole of our life course.
Beautiful. Catalina, love to hear from you about gendered ageism and the intersection with race, ethnicity.
I think there have already been very comprehensive answers, so I will just add, as you were saying, more of the structural factors you were referring to, Ruth, as well, in terms of when migrant refugee women and gender diverse people are also trying to access this healthcare system, it's coming across those extra challenges, as you were saying, Ruth, like racism. But also it's very difficult to navigate healthcare system and how's the system actually supporting people to navigate that, as well as the isolation that happens during that migration process. So healthcare, a difficult to navigate healthcare system can further enhance and amplify that isolation. And when it comes to the more use of digital platforms in the healthcare space, that can also, without taking into consideration capacity building, can again isolate certain groups. So I think that, along with what's been said already, as well as the added stresses that come with aging, which also comes sometimes with increased caregiving responsibilities. And for migrant refugee people, that might also mean transnational caregiving, so for people overseas. So there's a lot of layers there that need to be considered, and that's why it's important to look at how the system is isolating different groups and how we can, change the structure to address those barriers.
I'm thinking, as well as you're speaking, Catalina, are there special things also that we need to be thinking about in terms of people on temporary visas?
Yes, I think there are a lot of limitations in terms of who has access to healthcare here. And an example of that, as you said, is temporary visa holders not having access to Medicare, but also how culturally and linguistically responsive some of the services are for people that do have access as well. So there's a lot of added costs in that, and searching for the right GP as well.
Lifelong search, I find. Michelle, have you got any thoughts to add to that question?
Yes, I guess what I've been thinking of is is that I think mental health plays a big role in both the actual healthy lifestyles and well-being of older people, but also represents a challenge around seeking appropriate care. I think this is particularly stark for the trans and gender diverse community, where at least 3/4 of the community experience anxiety and/or depression in quite crippling levels, and this makes seeking healthcare difficult. And it also adds a dimension to the overall health of the being. It's a health and well-being of the individual. I should add that these mental health issues don't arise per se from the fact that being transgender creates, or gender diverse creates, mental health issues of its own. It arises from the discrimination, prejudice, and abuse that we experience as particularly trans and gender diverse women. And I picked up on something someone else said. We really, really need to, in the healthcare systems, treat the whole person, see the whole person. And when you come to a healthcare professional as a transgender person or a lesbian or some other member of the LGBTI community, that really needs to be seen by the healthcare professional, and it needs to be made obvious that the healthcare service that you're accessing is inclusive of those identities, as it should be about all other identities as well.
Thank you, Michelle. And I think what you raise are both the internal and societal and structural barriers that are there, because once someone actually gathers themselves enough to go and access healthcare, which I don't know about you, any of the people watching, but I'm not a big fan of accessing healthcare, even though I have a nursing background. You know, it's kind of like to then be confronted with microaggressions, interpersonal kinds of lack of knowledge, lack of care, lack of sympathy, lack of understanding, both at an interpersonal level, but also systemic level, in terms of the forms that are available, in terms of language material. So the kind of language that's being used that might be trans exclusive and so on. We've got so much work to do. And I feel like we've done so much work around culture, ethnicity, disability. But I do feel like gender diversity is where we need to do far more work, speaking as a health professional who's been involved in undergraduate and postgraduate education for a really long time, because it's the kind of world that's enacting this violence that you're talking about, Michelle, on people. Yeah. So, all the individual strategies we have are inadequate for this kind of overwhelmingly kind of negative, really disempowering kind of world. So, thank you for that perspective. Yeah. Can we, I feel like the clock's ticking and there's so many really interesting things we could be talking about, and we could talk about this for a day. So people who are watching, forgive me for moving quite fast through some questions, but I'm really keen to sort of maximize the time that we have with this incredible panel. So I want to maybe start with Catalina for this one. And my next question is really about what does a good inclusive digital resource look like in the health context? And now I've got a dog barking. And what does good co-design in health look like? And, I'd really love it if you shared some of the experience. And I also take on the point you made earlier about, unless we're building capacity as well, the people who stand to benefit from that co-design are unlikely to receive those benefits.
Yeah, thanks, Ruth. So to build on the point about capacity building, for it, to be really inclusive, I think we need to acknowledge that there needs to be capacity building outside that digital space as well. And I specifically wanted to mention that because a lot of capacity building that is about digital devices and navigating digital platforms is only accessible digitally. So I think what needs to be considered is that they don't exist in a vacuum. People's health exists outside this digital realm. And so that capacity building and health promotion initiatives also have to be outside that. So what I mean by that is, for example, having health education or capacity building workshops around navigating those platforms, around how to book, use an online booking system, rather than having those be made available online, but then you're still not connecting that with the people in the community. So I think that has to be more of that connection considered in the implementation. And that connection, when it comes to migrant refugee communities, what languages you're making that accessible in is also important. So I think it's really about that, and about also who has access to digital devices and reliable internet. So it's considering all those factors in their implementation to ensure they're inclusive. And in relation to the co-design of that, I think it's about involving people in the process early on and throughout it, and also being transparent about how much say a participant has when they come into that co-design space. So at what point are you engaging with them? What are the timelines? How much decision-making power do they have? Just to be really share that power. And yeah, I will let others add to this because I think I could speak on this for a while.
Catalina, great points. I wonder, Vicki, if you'd like to compete with this tree that's been cut down and talk about it, because I think the idea of co-design and like you say, Catalina, engaging people early, engaging them often, making sure resources are available in appropriate languages and so on. I think there's some similar threads, Michelle and Vicki too. But I wonder if we could start with Vicki, then go to Michelle and then Jackie to talk about, you know, how you might engage with the communities that you're involved with.
Thanks, Ruth. So I've been involved in the Experts by Experience health project with women with disabilities for 3 years. So this project aims to increase access to health services by building the capacity of women with disabilities, workforces and organisations. So resources and workshops support women with disabilities to learn more about their health rights, navigate the health system and then advocate for themselves. Health professionals and staff are supported to make services accessible through workforce training and resources. So the centre of the program is the Health Experts Group, of which I am one. So who are a diverse group of women with lived experience of disability and who are employed to engage in consultation and co-design activities. So this is one of the things that WDV do push, that good consultation and co-design means a shared employment, if that is the way that groups are going or committees are going. So the experts in our health resources, workshops and training all centre lived experience, and each has been co-designed by the group. So a best practice end-to-end co-design process has been used so that the resources and training sessions truly reflect the experience and values of women with disabilities. A co-facilitation model was used in the delivery of training, allowing the health experts to purposefully describe their own experiences when speaking to communities of women with disabilities and health workforces. So the telling of our own stories is the point of difference that we have, and proved to be a very powerful tool in creating empathy and leading to call to action. Each health experts group member played a role in the production and promotion of all of the resources, from appearing in the video to consulting on social media strategy. So in centering the expertise of women with disabilities across all activities, this project provides an example to organisations of effective co-design practice.
Very comprehensive, Vicki. Michelle, have you got some thoughts about co-design? And
yeah, I do. I am part of a committee that's bringing to Victoria I'm part of a consultative committee that's talking to the people who are bringing to Victoria Pride Centre in September an exhibition which is in part about Magnus Hirschfeld and his Institute for Sexual Wishcraft or Sexual Science. And Magnus was a physiologist and physician and sexologist who really pioneered the development of hormonal and other treatments of trans and gender diverse people. And his institute had on its employee list trans and gender diverse people, and we're talking about in the 1910s and 1920s here, so very early on. And he worked with them to develop a system whereby they were given cards so that they wouldn't be arrested by the police on suspicion of being prostitutes. They worked on them with the use of the then very new hormonal treatments to affirm their gender. And he actually, worked with them to try and help them get jobs elsewhere and to have a social network, primarily through various clubs and associations. And so he had a very comprehensive attitude towards the health of his trans and gender diverse people in his client group. But he developed that in collaboration with them. Moving on, nearly a century later, we have gone through a period where health experts have really taken over the trans and gender diverse health care and developed a real system of gatekeeping about who can get access to trans and gender diverse healthcare. Fortunately, that's breaking down, and organisations like the World Professional Association of Transgender Health and its Australian affiliate, OzPath, are now including transgender people and advocates within their body, so that they do sit and work on co-design of how to best achieve holistic healthcare for the transgender diverse communities. So that's my little sixpenneths on co-design. We've gone from a situation where a health expert worked with individuals to achieve a viable healthcare system to somewhere where it's now reverted. It's gone from being managed by the God physician back to being an interactive system, which is how it should be.
Thanks, Michelle. I'll move to Jackie to say a few words, but before you do, we are doing really beautifully on time. Amazing. I think it's because all the panelists are really scared of me because I'm a mean timekeeper. So we may have time for a few questions if you want to pop them in the chat. After all, we may not get to all of them, but let's have a try, because my sense is these panelists know a lot of stuff and might have a few more things to say than the questions we have. Over to you, Jackie. Your thoughts about co-design, good digital resources.
So I think we've had some really great discussions and examples here about how to do it well, and I think In My Prime does it well. I think, having seen over the years a lot of not so well done ones, the reality is, particularly in Australia, that a lot of them are aimed at well-educated white people generally, and people do mean well and will get things translated, but that's not necessarily addressing the bigger picture and cultural needs and other aspects. So it's a start. But I think part of the problem comes from not really building it in, as has been described from the very beginning, and having that systems commitment and the budget commitment, because it's really important, if we are doing this in partnership with people with lived experience, that they are paid to share that experience. And as I think was mentioned by Women's Health Victoria really early on, even things like looking at what words people search. When we were doing a mental health project with some women, and there were women from an Arabic cultural group who were saying they search for affection, because if their mental health is not good, they're wanting affection and to feel that they're loved. So, it's quite complex, and we absolutely need that lived experience from the beginning to the end, as everyone has really described.
Michelle, you have your hand up.
Yes, I just, in talking about co-design, I think there was a digital health aspect to your question, and I think digital health has proved a blessing for trans and gender diverse people in many ways. It makes them very much more comfortable, often, if they've got access to the right internet resources, to actually seek help. And even more than that, it's provided people living in rural and regional areas of Victoria and the country in general access to experts that would otherwise involve them in travelling many hours by car. and it has opened up things enormously. I think it's very critical for the older people to be able to access digital health, and it is a barrier. Definitely, the technology is a barrier for people, and having, I suppose, regional resources councils, libraries producing training so that older people can get familiar with the internet and internet access is a critical thing, I think. So thanks.
Thank you. I would like to ask you, what if we could remove all the barriers? I know, I'm dreaming. What could we do to remove some of the barriers, most of the barriers, all of the barriers? What can we do to make sure that we're not just centering, as you were saying, Jackie, well white women who know how to use services, and I should say white, straight, cis, able-bodied, the people that are able, what can we do to remove the barriers for the people who are more marginal? Who wants to start with that one? And I think, Vicki, you've given us, I've got a ton of notes I've been taking. You've given us loads of information, but Michelle, you're waving your hand, and
Okay.
then maybe we'll go to Vicki.
Vicki's almost beat me to it with her raise of the hand. I went the analog route. Look, I think removing barriers is very important, and one of the things that really gave me heart when I went to the Australian Society Professional Association for Transgender Health conference recently was the number of healthcare professionals who are trans and gender diverse themselves in Australia. It is starting to increase. I have 2 non-binary doctors in my health practice. I have, and this is a big thing. And I think when you go out to migrant communities, increasing the diversity of the healthcare workforce is a very critical thing. And it's just an observation that if you can see someone like you in a healthcare practice, it makes a great deal of difference. Even down to the receptionist. The receptionist can be very important. There's a couple of there's one transgender woman and one non-binary receptionist at my healthcare clinic. So it makes a big difference.
Yeah. Michelle, one of the things I'm concerned about is that presence equals power, that we assume because you can see a brown face, a trans face, a person with a disability, that somehow the problems are fixed. And of course they're not. They're encouraging signs, but they're inadequate in of themselves. And I'm supervising a PhD at the moment, looking at what it's like to be trans as a nurse, a research project. So I'm really encouraged by those things. But yeah, is it enough to just be there is a big question for me.
I agree. It's just a starting point. But if you can't think of the inverse, if you can't see anybody like you in a healthcare practice, it presents an additional barrier.
Absolutely. Thank you for that, Michelle. Vicki, your thoughts?
So one of the catchphrases, I suppose, that we talk about a lot is nothing about us without us. And I think it's actually really important, this centering lived experience and making sure that people who are going to be involved in a service or whatever are actually talked to about what they need. And rather than this expectation or assumption that somebody knows better than. And I think, again, it's that conversation about asking us what we need, making sure that everybody has responsibility for accessibility. And that goes to, from what Michelle was saying, from the specialists right down to the people in reception. We need to make sure that that language is also accessible. That's a big thing that I'm really passionate about is making sure that language is accessible to the audience. It's not the audience role to actually understand what you're saying. It is your role to make sure that your audience understands what you're saying. So before I get carried away, I will stop and let somebody else jump in.
I actually really love it when people get carried away. We've got a couple of comments in the chat that I'd like to just read, and maybe that gives you, Catalina and Jackie, some time to think about the question. So Sharon Luna, who's amazing and is on Dharawal country, says lack of access to subsidized traditional medicines, the dominance of Western medicine. Medicare covers those, but non-Western medicine like traditional Chinese medicine, lomi lomi, Wellbeing massage, Mayan abdominal massage are not covered. So I think that's a really important kind of comment as well about, what is the range of options available to people that meets their healthcare needs. And Catalina, you might have some thoughts about that too. And then we've actually got a couple of other ones from Kate Johnson-Atata from WHV. Often the organizations who fund the development of digital health resources don't provide enough time or resources for good co-design. Have any panelists noticed any positive change in the space? We'll jump on that one after we finish this little loop that we're doing maybe. And Nicole Knight says training for health professionals on diversity and actually listening. Ooh, and taking time to understand what women are saying. It's a big one. It's simple and it's complicated, isn't it? So maybe let's just keep going with the removal of barriers, and then we'll finish up with Kate's question perhaps about positive changes in co-design. Catalina, do you want to say something about what might help in terms of removing barriers?
Happy to. And I'm happy to draw on what's also already been mentioned about listening to the needs of the community and making sure that our approach is really taking that into account. So, for example, drawing from our peer-to-peer health education model, and in particular our National Health in My Language project, I think what we really learned from that, and also from doing that previously for years in a state level, is how offering in-language health education to migrant refugee communities is in such a safe and inclusive environment is such a powerful tool to empowering our communities and to also facilitate that social connection and a sense of belonging in Australia, which I think is really, really essential. Especially as I mentioned earlier, there's so much social isolation that happens in that process of migration and the healthcare system when it's not tailored to migrant refugee people's needs. So I think there's a lot more unpacking of that in terms of what that means for older women and gender diverse people as well. For example, with our submission to the Senate inquiry into menopause. So I think there we offer how we can draw from the success of this peer-to-peer model and how we can address also those barriers that exist in menopause and perimenopause. But as we talked about, health and well-being for older women is beyond that as well. So I think it's making sure that that is accessible, not just in multiple languages, but also multiple formats. And that is, again, being responsive. So is video the best way? Is audio? Is print or digital the best way to pass on this information? So yeah, I think it's just empowering communities, but also making sure we're addressing those structural barriers to getting that healthcare access and healthcare treatments as well. So it goes beyond just having an appointment with the GP. It's also about the treatments that are accessible after that as well.
Thank you. We'll go to Jackie and Michelle. I think you've got your hand up, so maybe Michelle after Jackie.
I guess if you're talking about barriers to healthcare, I think we really need to address the cost of healthcare and in a broad sense. So not just the cost of seeing a doctor. It does, as I think has been mentioned in those comments, it needs to be more holistic than that, particularly when we're thinking about preventive healthcare. I think we can absolutely and should be training our health workforce to deliver more individualised, culture responsive and person-centred care. And I think leadership, more diversity in leadership would help drive a lot of those changes, because I think if we have that diversity, then those things are more likely to be recognised as important.
We've got 2 minutes, Michelle. I'm going to give you 10 seconds, I think.
I just wanted to throw in that peer navigators are a system that's being used with trans and gender diverse healthcare, which is really good. The concept being someone who understands the healthcare system will consult with a trans and gender diverse person and say, go and see this psychologist, or go and see that GP, or go and see that specialist. And it can be a very helpful thing.
Love that, Michelle. Thank you. That was very short and sweet. I'm going to ask people who have been listening if they could tell us one thing that they might take forward into their own work from listening to this webinar today. Please feel free to give us your feedback in the chat. So something that's really resonated for you. And I'm going to read some of the great points that I've got on this gigantic piece of paper. So I'm going to read all the words: gatekeeping, in-language health education, ideas of belonging in Australia, tailoring, multiple languages, multiple formats, empowering communities. Oh, I can't read my writing. Cost of healthcare, not just seeing the doctor, holistic, particularly preventative, more individualized, digital resources are aimed at well-educated white people, should be more than just translations, should be built in from the beginning. Can't do digital without building capacity. Can't read my writing. We're groomed to be good patients. Women's health concerns are often gaslit. Healthcare should be trauma-informed. That's the gold standard. Becoming involved in your own care. Safety, physical, cultural, spiritual, choice, control, collaboration, power, trust, boundaries, empowerment, informed decision-making. Yeah, I'll stop trying to read my writing. Timely and appropriate. So what are the thoughts that are leaping out to you as we come up and I begin to close? Please feel free to add to the chat. I'm going to end with some words for you. And I've been thinking about being on the margins and being marginal and being on the edge. So I'm saying to everybody in this virtual, beautiful room that we've shared for an hour, are you worried that your work is marginal? How would you feel if it turned out to be cutting edge? Edge is a synonym for margin. No one ever identifies the cutting edge in advance. Only in hindsight can we see it. The person who's now lauded as starting this exciting new approach to whatever it is was once toiling away in obscurity, probably thinking that their work or their life was marginal. Does it change how you think about your work or your life if you imagine that you might be on the cutting edge? How would you get this work out there so that others can be inspired by it and take it in directions you can't imagine? I'm now going to hand over to Shannon to close for us, but gosh, I want to hear more of you, all of you. That was so brilliant. So much to think about. You're all amazing. You get a car, you get a car, you get a car, and you get a car. If I could, a virtual car. Shannon, are you going to close?
Yeah, thank you so much, Ruth. And thank you, panelists, Michelle, Catalina, Jackie, and Vicki. As Ruth has said, we could sit and listen and join in on this conversation, I think, for many more hours. But we're deeply grateful to you for your generous engagement with the topic and with Women's Health Victoria. I'm just going to quickly share my screen, which has the QR code in. We would love people to give us feedback on this, which can help again to inform the work that we do and to inform any future webinars that we may host. So I'll stop there. The survey link is also in the chat, and we'll also send it out with a link to the recording when we put that up on our website. So I will release everybody now, and thank you again to you all and to our audience for your thoughtful engagement with the panel and with this topic.